All right, so these are my disclosures. As you see, I do speaking for pharma and matters of APC. So my task here is to kind of give you an update on what LUGPA is about, what we've done, and where we are headed. This is a condensation of what I talked about at our LUGPA national meeting for those who were there in November. Not much has changed in the last 2 months, so if you've heard it once, it's a good time to get on your iPhone perhaps and, oh Lord. All right, so as we all know, we kind of exist in a chameleon type of a profession here. I mean, nothing is the same. It's rapidly changing. There's, every day it's something new. We have to deal with regulatory issues from the government, healthcare, patients, and looking at what some advisors claim that, with the government struggling to manage payments and the cost of healthcare, skyrocketing out of sight. Right now, it's a $3 trillion industry, and if certain people get elected, it could be a $6 trillion a year industry. It's expensive, and people don't want to pay, and new technologies and all of these new things that are happening. I'm just struggling. There you go. All right, so technology. We always have new technologies, we always have new medications, we always have new devices, and they're all expensive, and they take a lot of time to develop, and because of that, there is a cost to it. So we have to balance that with how we're going to pay for all of it. All of our patients are becoming bigger consumers. They're all Google MDs. We also have to figure out making them happy with our Press Ganey reports, and the patient who loves you and writes a 5-page thing of how wonderful you are and then gives you a 70% on your number. And if we don't score in the 96th percentile now, we're not being considered to be doing a good job. I mentioned costs. They continue to go up, and they will always go up as long as there is somebody else paying for it and a great need for health care. And the demographics of our society. I mean, the population is aging, and all of these things continue to add more people to the healthcare expenditure. Lots of things going on in the market. I don't know if you're all aware, but many of us are, about private equity. There is kind of a feeding frenzy going on in urology right now. We have about 3 3/4 groups that have gone private equity. I think the 3/4 group may be there any time now, and many other groups around this country are looking at it. What that's going to do to urology, I don't know. It could be great. It could be horrible. Only time will tell, but it is a force out there, and it is kind of sweeping the country. And of course, regulatory reform, which we are integrally involved with, and we'll get into in a little bit. So we're obviously a trade association that is interested in our constituents, and we ask our members, what's our value to you? Because we're here for our members. I mean, we're a trade association, and we represent our members. And without question, and we know this, the advocacy work we do, which I'll dive down to a little bit in the subsequent slides, is predominantly, I think, our forte. We do it. I'm just going to pat ourselves on the back. We do an amazing job with advocacy. Networking is also huge. So when people come to LUGPA meetings, they just love to talk to each other. We have about 2,500 members now. What is it, 150 groups, Celeste, something like that? How much? 153. Okay, 153 groups. We have our CEO, Celeste Kirshner, sitting there, who's doing an amazing job. And they love coming to the LUGPA meeting just for the opportunity to talk to each other, because so much of us learn from our colleagues and how to do things. And really, from the inception of LUGPA, that's always been one of the most important things that we've offered. And really, our goal, our mission, is to protect independent urologists, and I think independent practitioners in general. I mean, a lot of the stuff that we do really benefits a lot of other specialties also, and in many instances, we collaborate with other specialties to achieve our goals. We do also participate in education. I mean, that is something that's important to us. I mean, obviously the AUA is kind of the 10,000-pound gorilla there, and we certainly aren't trying to compete with them, but we have some very, very talented people in LUGPA who work very hard and bring amazing educational opportunities to all of our members. And then the 9%, whatever that may be. So we asked them to describe in the past and the future, and the things that really come out is that, is this advocacy, collaboration, strategic, professional, and that even in the future, what they expect of us to continue to go along those links. So we love to say amongst ourselves that we're flyweights that punch like heavyweights as far as our weight in DC. And I don't think it would be too much of a stretch to say that we may be in urology the most influential as far as moving the needle with health policy. And I know many of my colleagues in the AUA may bristle at that, but we do work hand in hand with them and with the AACU to accomplish our goals. But I think we, being smaller, are very nimble and very facile, and we are able to raise money. We use lobbyists, we use healthcare attorneys in Washington, and we can really move quickly and swiftly to accomplish some of the goals that we have. So what are our goals? We want to protect independent urology, as I mentioned. We want to enhance leadership. We want to ease operational challenges. We want to grow, of course, and we also want to become more excellent. I think most of the LUGPA groups are, really strive towards excellence and do a great job. So we are really the only trade association in the country that represents independent urologists. And as mentioned, we have high-level health policy information, cutting-edge clinical education and business resources. We provide solutions to day-to-day practice management with some of the things that we offer, and we'll get into those in subsequent slides. So as far as some of the health policy, we firmly believe in site neutrality, okay? And that is, we don't really expect anything more than anybody else, but we also don't want to be given the short stick. And we really feel that we should be on an equal footing with hospital systems, that just because a physician is in private practice and then they go and join a hospital system, why should they be paid, the reimbursement 30% more? That doesn't kind of sit well with us. We think it should just be fair and that we should all get the same thing. We're also dealing with Medicare Part B, and there are always a lot of, so the way, as I'm sure Dr. Dunn will tell us, the way it's kind of done in Washington is, as things get more and more expensive, they get on the radar screen, and once they get on the radar screen, then people start thinking, well, how do we cut this? And all of our oncology drugs, certainly for the medical oncologists, this is really important for rheumatology, and for us, we feel that we need to have the ability to give our patients access to this. So Medicare Part B, primarily Provenge, is what we administer, and that category is very important for us to continue to administer, and we want that to remain at the compensation level that it currently is. MACRA and the IOASC, that's in-office ancillary exception, Stark reform. So, we're all moving towards value-based medicine. I don't know, we'll talk about that more, but that's really kind of the buzzword now, is getting value. It's just not about volume, And I guess in a perfect world, fee-for-service should go away, but I don't know if that's ever going to happen. That's going to be challenging. But certainly value-based medicine and advanced algorithms for treating patients and ways to have risk sharing to save money. These are all the things that are in the cards, and it's very, very difficult. It's impossible, really. It's illegal to get into a risk sharing scenario with the current Stark and AKS anti-kickback laws that are on the books. Now, a couple of months ago, HHS basically came out and said that there were going to be revisions. And that was something that LUGPA was very, very proud of, because I think LUGPA really was a very, very huge voice in getting that accomplished in Washington. As said, it's pretty amazing, but they oftentimes call us, HHS and CMS, to come to the table and opine, comment, put in our opinions on things. Amicus briefs, those are all the things that we do to help kind of move the needle to help our legislative agenda. Radiation therapy bundles also. Good thing, bad thing. The government comes up with a lot of things that, who knows what they're going to do. There's always the law of unintended consequences. But we certainly think that this potentially could hinder access to patients' access to cancer treatment. And we really look at that closely, and we want to make sure that there's a fair playing field with that. Medicare fee schedules we're always commenting on, and again, as I mentioned, the regulatory implementation for MACRA, and also our ability to continue with in-office dispensing. I'm going to give a talk about in-office dispensing and advanced APC clinics here in a little bit after Evan talks, and I'll get into that a little bit more. And also the other one that we all love in urology is our beloved United States Task Force. I think we're up to a C rating for PSA testing in 55 to 70-year-olds, and And I'm not sure that all of us really agree with that either. It's getting a little bit better, but work needs to be done on that. All right, we talked about Stark, we talked about site neutrality. We're not going to get that. Okay, leadership, very important. Obviously, the founders of LUGPA, we're all kind of getting to that generation where we have a lot of gray hair. We're trying to develop the next generation of leaders. And that is, we're starting a leadership program this year. LUGPA Forward, that's 400 members. Those are our youngsters that we have in the group. We are mentoring them, and we're trying to bring them along to come in and take our place in the ensuing years when we ride off into the sunset and to continue our mission. We had our first year Rising Chief Residents Forum. Evan, our secretary, did an amazing job with Scott Sellinger. It was very well attended. I believe this year, Evan, we have twice the attendance now booked up. It's very exciting to get the residents and to make them, listen, we do this, and I don't think we really bias anybody. I mean, those that want to go into academics, that's great. But we'd like to think that people who are going to go to a hospital system, maybe you should think about independent medicine and independent urology. We also do benchmarking, and this is something that we've just done. This is something that was always very important to us. Everybody kind of benchmarks, in the big LUGPA groups, we all kind of benchmark amongst our colleagues in the groups, but how are we doing nationally amongst all of our various LUGPA groups? So the benchmarking project was something that we've developed over the last 5 years. I think we finally, this year, got it up to speed. We partnered with a great analytics company. And this has multiple benefits. It has, as you can see, buy and bill reports, but where payers are inconsistent. But more importantly, there's such things as like stent removal tracking. I mean, imagine the numbers of how many stents are lost that we leave in patients or they disappear. It's really profound. And I guess, I'm going to extrapolate on that. I mean, everything that we do, whether you're patients coming back for prostate cancer follow-up, bladder cancer, I mean, when you really do a deep dive, it's pretty shocking about how many patients that we have lost to follow-up. And of course, that leads to not only bad patient care and bad outcomes, but litigation in our litigious society. So that is indeed something that this benchmarking project has done. LUGPA on site, so this is a program we started last year where we actually come out to various LUGPA groups and we answer any questions we have. We help them with any problems they may have, service line expansion, physician compensation, how to get along. That's a big problem amongst doctors and urology groups, and I think all groups. Sometimes we're psychiatrists and not just consultants. But we've been going on site, and that was a program that we initiated last year, and it's been quite successful. A couple of years ago, we put together a practice management for urology groups, and that was very successful, and we're going to get it updated. This is written by experts both in LUGPA and also some outside experts, so that should be available come November. We do have programs. I mean, Neil, I don't know what happened to him, but runs programs on prostate and bladder cancer academies that have both people who've been out in practice under 10 years, I believe, and also residents, and those have been highly attended. They're terrific programs. And we have our regional meetings, the so-called SLUGPAs. We're going to do a virtual March 4th and an April and June. And UroCare Live is just more educational stuff. And as I hit the 0 mark, I know David's going to harpoon me. So I'm going to finish here and just say that LUGPA is really working for everybody in independent medicine. I agree with Jonathan that I think that we're going to have a forum up here about how we can all work more collectively together with academics and with perhaps hospital-owned. But we continue to carry the torch for those in private practice and independent medicine.